This is the first time we do this as the International Achondroplasia Forum, and it's a great pleasure to welcome you all. So we have, let me see if the slides will work. No, I think you need to, it would not go forward. Let me see. Here we go. So first, some housekeeping. This meeting is being recorded and will be shared later on our website. And we highly recommend you to have your camera turned on, but please mute yourself during the presentations. We also encourage you to ask questions through this chat function. And if we have time after the rest of the presentations, we can take some of those questions then. And we will also have a session for questions and discussion at the end of the presentations. So please be active in the chat, and we will try to keep an eye on that. I think we need to go. It stops working. So next slide, please. And we have the CSIS medical team here to support us and provide us with technical assistance. Susanna, Alex, and Ifan. Next slide. And I also would like to draw your attention to the latest publications from the European Achondroplasia Forum. We have one paper recently published with the title Recommendations for Management of Infants and Young Children with Achondroplasia, Does Clinical Practice Align? And also, we just had another publication accepted. So keep an eye on this as well. This will be about sleep-disordered breathing in achondroplasia, guiding principles of the European Achondroplasia Forum. So those two, the first one is already out. The other one is to come soon. Next slide. And as we have been expanded to become the International Achondroplasia Forum, we also had some new members on the steering committees. I would like to welcome our new steering committee members, Dr. Julie Hoover-Fong from Baltimore, United States, Dr. Virginia Fano from Buenos Aires, Argentina, Dr. Joan Clinton Lerena Jr. from Brazil, and Ravi Savarirayan from Melbourne, Australia, and Dr. Kiti Okada from Tokyo, Japan. We are very happy to have you on board on this steering committee. And I would also like to thank our sponsors, QED, Biomarine, and Tyra. Without you, we would not be able to do these workshops. So thank you so much for your support. And now we're going over to the today's topic with the objectives to introduce the expansion of the European Achondroplasia Forum to the International Achondroplasia Forum, but also to examine the pathways affected in achondroplasia and related conditions and assess the potential targets for treatment. And we have an excellent faculty today will share their knowledge about this. And we'll also look into try to understand the therapeutic pipeline for achondroplasia and related condition and the outcomes that therapeutic options may impact. So the faculty of today, the first speaker will be Dr. Melita Irving from London and Andrew Dauber from Washington in the United States, Philip Bacaljo from Cincinnati in the United States, and Wolfgang Högler from Linz in Austria. So we're very happy to have you here today and to share your huge knowledge about these topics. So next slide. So here is the agenda, and Melita Irving will be the first speaker. And Melita is a consultant and a clinical geneticist at Guy's and St Thomas Hospital in London. And Melita has been part of the steering committee in the European Achondroplasia Forum since we started in 2020 and has an extensive experience in clinical trials. And I think you have been part of the clinical trials for achondroplasia since the very beginning. But Melita will now share with us the expansion into the related conditions and beyond achondroplasia. So please, Melita, we're very happy to have you here, and the stage is yours.
Thank you very much, Svein. Thank you for that introduction. And yes, it's my role to introduce the new kids on the block. So not only our new steering committee members, but also the related conditions. So I'm going to introduce you to both of those concepts. Yeah, I think I missed a slide. Maybe not. Okay, so yes, defining related conditions. Here's my slide. So I'm going to be speaking about what links achondroplasia, which is what we've been really focused on since the inception of the European Achondroplasia Forum. We've been obviously focused on achondroplasia. So I'm going to show you, this is not a leap of faith. I'm going to show you how there is a link to related conditions that we can now expand towards, and therefore how we can start to target treatment and potential outcomes that are beyond height for other conditions as well as achondroplasia, and how we're going to do that with the expansion to the International Achondroplasia Forum. So if we're thinking about expanding to other conditions, we know a lot about achondroplasia, but how do you spot a child with skeletal dysplasia? How do you detect it? How do you diagnose it? Because that's got to be your start point. So the way that I do it, the way that we generally do it, is in the good old-fashioned way of history, examination, and investigation. And here you may be familiar with this slide. It's one that beautifully illustrates the difference between a child with achondroplasia, the child on the right, and the child on the left, his fraternal twin, who doesn't have achondroplasia. So first of all, using your eyes is really important to determine the difference. But in respect of history, it's important to ascertain a family history to try and determine if there is an inheritance pattern that's running through the family that signifies one type of condition over another. Could it be X-linked? Could it be autosomal dominant? Could it be recessive? Could it be de novo, out of the blue? And understanding, therefore, the heights of the parents is really important. Has this been inherited? Is this constitutional growth delay because the parents just happen to be short? Could this be idiopathic, as some call it, or genetic, as I call it, short stature? So exploring the family history is very important and really valuable as that first piece of the puzzle. The prenatal history is also important in determining any features that were unusual, which might point to a particular type of skeletal dysplasia condition. For example, if they're a short femur length, when were they first detected? Did they improve? Did they progress and become progressively slower in their growth? The neonatal history, what happened in the neonatal period, and were there any issues with feeding or breathing, or any funny turns or things that may be seizures? What is happening in the developmental profile? Is cognition okay, or is it impacted? Is there any issue in terms of the different domains in respect of motor development, so gross and fine? Any issues with vision? Any issues with hearing? General medical profile can also point towards specific types of skeletal dysplasia condition. I'm thinking in particular, for example, of Noonan syndrome, in which we might find a disorder of the pulmonary valve, conferring pulmonary valve stenosis. And is there a pattern of sleep disordered breathing, which may indicate skeletal dysplasia, may actually even help us pinpoint which type of skeletal dysplasia. So across all of these different history domains, it's really important to look for clues which will start to build your list of differential diagnoses in detecting and therefore correctly diagnosing the skeletal dysplasia condition. History is followed by examination. And of course, we start with the growth parameters. At the very least, height, head circumference, sitting height, and weight. But if you have capacity to do other measures as well, that may also be important. I'm thinking here in particular of arm span. That's a stadiometer, sitting height machine. Facial features, so they can be very characteristic in different types of skeletal dysplasia condition. And once again, I show you here a child with achondroplasia who has a broad forehead, depressed nasal bridge, mid-face hypoplasia, and we can also see from him different body proportions in which he's finding it difficult to raise his hands higher than his head. That is difficult for infants, but it does improve, but not in achondroplasia. And you can see that his legs look short compared to his trunk as well. So looking at the different body proportions can also help you determine what type of skeletal dysplasia condition you need to be considering, if the trunk is affected or not affected, if the limbs are affected or not affected, and if they are affected, in which portion, rhizomelic, mesomelic, or acromelic. And if they're all of the portions are affected, so body proportions, really determining what's going on there can be very instructive. Looking at the hands, so this is a very characteristic hitchhiker thumb in a certain type of skeletal dysplasia condition, and a single palmar crease there, and those short digits. So looking at the hands can be really discerning, as well as are the teeth. So these are the teeth of a person with cleidocranial dysplasia, in which the permanent dentition, as you can see at the top there, has not erupted, and I think that's probably his primary dentition in the lower jaw there. So permanent dentition doesn't erupt, and there may be delay or not at all exfoliation of the primary dentition. Is there any bowing of the legs? Any abnormalities there? And this child has Schmidt metaphyseal chondrodysplasia. And so this is a very characteristic appearance of the legs. And the eyes, are the sclery blue, for example? Do we see any issues with myopia or retinal issues, as we see in the type 2 collagen disorders? History, examination, investigation. So we can do standard investigations, including bone profile and looking at vitamin D, looking at PTH, looking at phosphate and calcium, checking that there's no abnormality there, which can sometimes give you a useful guide. I'll come to radiology in a moment. This is our ace in the pack, really. And additional imaging post-diagnosis can be important as well, to monitor or look for other associated multi-system complications. So renal ultrasound scan in conditions that are conferred by ciliopathy, MRI brain, we know that's important in the achondroplasia diagnosis and monitoring, as is cervical spine views, flexion and extension in certain types of skeletal dysplasia condition, pretty much all of them that needs to be considered. And I put NB cranial ultrasound scan here because it's really not that useful. It's still done quite frequently, but we really don't find it very useful at all in terms of diagnosis or monitoring. So the ace in the pack, oh, not yet, but ace in the pack we'll come to in a moment. But when we complete our investigations, and we have our diagnostic list of suspects, the next thing that we want to do is to do genetic testing to see if there is an underlying molecular abnormality that we can use to define to confirm the diagnosis, but also to understand how it happened. With FGFR3, if we're suspecting something like achondroplasia, it's reasonable to go straight to that gene and just do a single gene analysis. But increasingly, we adopted a next generation sequencing approach, when you can examine lots of different genes in one go, one test, examining across lots of skeletal dysplasia conditions. But you can't miss out all of the other bits and go straight to next generation sequencing, because as I put it here, junk in, junk out, we are plagued by variants of uncertain significance, which mean if you go straight to next generation sequencing and you come up with a variant in genes which are associated with certain types of skeletal dysplasia condition, and you haven't done all of that background work, then the list will be useless. So it is much more useful, especially for bioinformatic filtering and interpretation of all the variants that are generated through this process, to have a very clear diagnostic differential diagnosis list before you go to next generation sequencing, so that you can really maximize the power and the information that's generated from that sequencing process. So single gene testing is reasonable if you know which gene you want to go to and you have that available as a single test. Increasingly we don't, but FGFR3 we do. We can do skeletal dysplasia focused panels, but we can also do exome sequencing. So looking across multiple genes associated with looking at the sections, the portions that are in charge of coding the proteins, the exons, collectively they are known as the exome. You can look at them in the individual themselves, the proband, the patient, but also it's really useful especially in terms of filtering out the variants that you don't know if they're significant or not, if you do this as a trio and you can compare the exome variants found in the proband in the patient with that of the parent. So if you think that it is an autosomal dominant condition, you're going to filter for variants that have been passed from one of the parents to the child. If you think it's recessive, we're looking for carriers, parents being both carriers of the variant in the same gene that they both transferred to their child. If we're thinking of something de novo, because there's absolutely no evidence that the parents have any condition, then we're looking at something that the patient has, the proband has, that has not been inherited because neither parent has it. So it's de novo. And that same process applies to genome sequencing, which again is a frequently used platform nowadays, mainly because it helps us look at the exome better. It helps us look at the junctions between the junk DNA and the exons. I think there'll be more to come from whole genome sequencing in the future when we find out what exactly is going on in that junk DNA, because it sure as hell is not junk. There's something very interesting going on there that I think is going to help us with these diagnoses and understanding the pathogenesis of these conditions. Pretty soon, I think we'll be there. But here's our... Could you mute if you're... mute
çok
everyone,
güzel.
please? Just let me speak. Thank you. So this is our ace in the pack, radiology, the skeletal survey. So if we add that to the history, examination and investigation package, then this can help us really drill down into the exact type of skeletal dysplasia condition. This is achondroplasia. There are characteristic features here that are like nothing else. This is only achondroplasia. So that helps you to know to go straight to your FGFR3 gene. And we have expert radiologists across the world who are able to interpret these radiographs and help us with the diagnostic process. So that's how we assess things clinically. But what about linking achondroplasia and related conditions? How do they all link? Why is this not a leap of faith? Well, if we look at this cartoon of a growth plate, the cartilaginous growth plate at the growing ends of the bones, we can see, can I do a pointer? Possibly not. No, we'll use the cursor then. Stuck. If we look at the proliferating chondrocytes, so in the cartilaginous growth plate, this around the outside, I hope you can see my cursor. Please, someone tell me if you can't. That this is the extracellular matrix in which these cells are sitting, and these cells are chondrocytes, cartilage producing cells, and they are at different states of maturity. So here are the resting chondrocytes, and they start to proliferate and become larger until they are large enough to do their job. Their job is completed, and then they are removed, and bone forms in place of the cartilage extracellular matrix. So here in the proliferating chondrocytes is where the FGFR3 gene expresses its protein, the fibroblast growth factor receptor type 3. So a key player in the cartilaginous growth plate. So there are other key players in this process as well. They can be grouped in different ways, but what I've done here is to group them in respect of the role that they play in endochondral ossification. So transcription factors such as RUNX2, SOX9, and SHOX. Signaling factors. So we've already talked about fibroblast growth factor receptor type 3. There are other signaling factors in the growth plate as well, the Notch signaling pathway, the Wnt signaling pathway, the TGF-beta signaling pathway, and the bone morphogenic pathway as well. And each of those receptors have ligands that are the things that link into the receptors, and signaling pathways include a number of different proteins in that pathway. So there are multiple players even within the signaling pathway and ligand group of proteins and genes that are important in the growth plate. Growth factors like insulin growth factor 1 and the different extracellular matrix proteins. There are multiple of these proteins. I've picked out here the collagen group, which are important in the extracellular matrix in the cartilage, type 1, 2, 9, 10, and 11 collagens. So these are all really important players in the cartilaginous growth plate. And when they go wrong, they confer a skeletal dysplasia condition. And in the old days, when we didn't really know much about skeletal dysplasia, it wasn't so well defined. It certainly wasn't defined molecularly very well. All we knew about was, way before, achondroplasia, eye cell disease, and when something else came along, which didn't look quite like either of those two, pseudoachondroplasia was the term it was given. But fast forward to 2023, the last iteration of the nosology of genetic skeletal disorders, we now know that there are 771 separate skeletal dysplasia conditions accounted for by 550 associated genes. So most of those 771 conditions are now defined molecularly and by over 550 different genes. So this is a huge number of conditions to consider. And the nosology helps us do that by grouping the conditions into different categories based on different things. But here I'm showing you group 1 and group 2, which are defined by the gene and the protein that is associated with the conditions. So FGFR3, fibroblast growth factor type 3, we know is associated with achondroplasia and hypochondroplasia. And type 2 collagen is associated with a spectrum of other disorders as well, all characterized by the fact that the type 2 collagen is either of a poor quality or a reduced quantity. So we can start to define things and understand them more closely by really following what's going on at the genetic and therefore the protein level and where those players are important in the bones. And then that helps us target treatments and potential, it helps us target treatments and helps us to target other outcomes about skeletal dysplasia conditions that might not be related to height at all. They could be to do with pain or to do with functionality or to do with improving the complications. But that's the start point, understanding what went wrong in the first place to see what can be implemented to improve the outcome. So with the FGFR3 story, what we know is that there are a number of conditions that are allelic. They're all caused by pathogenic variants in the gene that encodes the fibroblast growth factor receptor type 3. Here I've highlighted achondroplasia affecting the transmembrane domain because that's where the pathogenic variant that is recurrent and causes achondroplasia is found, impacting the transmembrane domain of FGFR3. But here there is hypochondroplasia at the tyrosine kinase domain. The two different domains, but there are other conditions as well, thanatophoric dysplasia type 1 and type 2, and SADAN, which is severe achondroplasia, developmental delay, and acanthosis nigricans. So SADAN and TD for another day, but please focus here on achondroplasia and hypochondroplasia as we're on the FGFR3 story. So ordinarily, just to give you a bit of background in why it's important to understand the pathogenesis here, is that the fibroblast growth factor receptor protein sits astride the membrane of the cell membrane of the chondrocyte, that cartilage-producing cell in the growth plate. I showed you that cartoon, the proliferating chondrocytes where FGFR3 is expressed. It's waiting for its ligand, the fibroblast growth factor ligand, to slot into that receptor like a piece into its puzzle or hand into its glove. And once that slots in, two receptors then join together. They dimerize. And it's that physical dimerization, that bringing together of the receptors, that then fires off the signaling pathway, the FGFR3 signaling pathway, the role of which is to inhibit endochondral bone growth. So if you stimulate this pathway, you stop bone growth. In the face of the pathogenic variant that causes achondroplasia, substitution of glycine at amino acid 380 for an arginine, that process of the dimerization occurs in the absence of the ligand. And it's that dimerization that then fires off the signaling pathway, inhibiting bone growth. So this pathogenic variant inhibits bone growth, and that is the cause of achondroplasia. So now we know that, we can start to target treatments that will stop that from happening, that will block that process. We can either use a ligand trap to get rid of ligand to stop that also stimulating the receptor. We can completely blow the receptor out of the water. We can stop the receptor from working. Or once that dimerization has occurred and those signals are fired off, we can block the signals. So there are different strategies that we can use, but we only know how to do that because we know what has caused achondroplasia. And the way that we have been exploring ways to stop, to alleviate achondroplasia is by the first one, blocking the signal. So using a different pathway that cross-talks with the FGFR3 signaling pathway in an inhibitory way. So if you stimulate that pathway, it inhibits the FGFR3 pathway. So this is the NPRB, the natriuretic peptide receptor type B pathway, which inhibits the FGFR3 signaling pathway. You stimulate that with its ligand, C-natriuretic peptide, that will have the effect, but C-natriuretic peptide in its native form lasts for 5 minutes in the body, and that's not long enough to get it to the growth plate where it needs to have its action. So vosoritide is what's the word? Synthetic. I don't know if somebody just said that. Synthetic form of C-natriuretic peptide, which then slots into the NPRB receptor, triggering the pathway, inhibiting the FGFR3 signaling pathway, therefore releasing that inhibition on endochondral bone growth. So that's one way. That's, once it's all happened, tackling the downstream effects. Another way is you can stop the receptor from working. You can use a tyrosine kinase inhibitor, such as infigratinib, which is an oral therapy which is in development for achondroplasia, and is in phase 3 studies at the moment. But by blocking this receptor, you stop that. You stop the FGFR3 signaling pathway in its tracks, which means you can tackle not only the RAS-MAPK pathway, which we saw reduced in the vosoritide with the C-natriuretic peptide, triggering the NPRB pathway, but you also inhibit the STAT1 pathway as well. So there are two pathways that come from FGFR3 signaling signaling, and they can both be blocked by inhibiting the receptor by blocking the tyrosine kinase domains. So it takes a lot of understanding about the pathophysiology to be able to develop something like that. But once that was done, we can now start to tackle the wider implications of conditions like achondroplasia. So not just the cumulative height deficit and the disproportionate growth, but everything that comes from that, diminished quality of life and multi-system complications, all inextricably linked, but all very much features of living with achondroplasia. And because this is so complex, we have guidelines that recommend a multidisciplinary and lifelong care of individuals with achondroplasia. And at the moment, we have no reason to think that's going to change, that the multidisciplinary care will be just as important in light of treatments as it was prior to treatments being available. But it's complex. And so one of the things that's important in these conditions is to have a plan for multidisciplinary lifelong care, but try to reach some consensus, because we still recognize that there is not very much evidence-based, there's not much evidence base to be able to determine these recommendations for treatment and for management guidelines. And so we have to do that as reach a consensus. And typically that's done using a modified Delphi process. And that means, therefore, that we can produce, with many people involved, reflecting the multidisciplinary care requirements, consensus statements and consensus guidelines on how to manage these conditions, which go into a lot of detail about all the separate complications. And here I'm singling out the foramen magnum stenosis that concerns us greatly in infants with achondroplasia. But it's important as well as generating those guidelines to really map out with a lot of detail the natural history of things like foramen magnum stenosis and the complications that occur as the result of these conditions, whether they are achondroplasia, wider skeletal dysplasia conditions, or any rare disease, in fact. And here is just a snapshot from Julie's paper in 2021 of what was going on at the time in terms of natural history studies, looking across different age ranges and different regions and focusing on different elements of achondroplasia in particular in terms of the complication burden and the natural history thereof. And so once we're able to delve deeply into the natural history of a particular aspect of a condition, that then means that we can start to focus on how to factor those complications into treatment outcome and how to design a clinical trial or how to design a treatment that will help focus on the particular complications. And it is multidisciplinary and it is very complex, and that really is true. This slide is used really to illustrate what is required in achondroplasia, but it applies to all skeletal dysplasia conditions. And it is lifelong because these conditions don't stop at 18. In fact, they not only do they carry on into adulthood, but the complication risk and the impact changes to reflect the fact that it's now impacting an adult. And it's very much true to say that what happens in childhood can also impact adulthood for those people who are affected. So multidisciplinary care, which is lifelong, is absolutely vital across all skeletal dysplasia conditions, not just achondroplasia. So this is all hands on deck. And we have produced in a previous piece of work with the European Achondroplasia Forum this practical guide to manage or to help adults with achondroplasia be cared for. We recognize that the situation for adult patients is different to pediatric patients, in which there doesn't appear to be a natural home for them like there is for children with achondroplasia or indeed with skeletal dysplasia conditions, and that adults with achondroplasia don't want to present to hospital every 5 minutes or present to medical care every 5 minutes. They want to get on with their lives. However, as I said previously, there is still a significant complication burden in adults that is evolving in those people, which means that they definitely do need care, even though they might not choose to actively seek it out. So this is a compromise between allowing adults to get on with their lives, but to have regular checkups that are easy to be conducted. And we think that this is a really useful document to help those people take it to their primary care physician each year and say, measure my blood pressure, ask me about this, weigh me, ask me about pain. And if I answer this, then send me here. And if I answer that, just see me next year and let's do it all over again. So we think that this is an empowering and enabling document that can ensure that we can compromise. So what are the beyond height effects of treatments aimed to do? Well, improve health-related quality of life, perhaps through improving body disproportion. So helping height means legs have grown, but also arms will grow as well as a consequence. And therefore, things that couldn't be reached before can now be reached. So we can measure this in respect of health-related quality of life, and we can directly correlate that with improvements in body disproportion. We're starting to get signals that suggest that there's an improvement in the craniofacial skeleton, and that may then improve the risk of sleep disordered breathing and the risk of foramen magnum stenosis. And further outcome measures will be analysed over the course of time. They take longer to generate, and they too could translate to improved outcomes. So it's really important that we keep collecting information about natural history and about how that changes in the face of treatments, because there could be an overarching benefit that takes a longer time to discern. So in that respect, the European Achondroplasia Forum has not only expanded to be international, and as Svein has already said, we're welcoming our colleagues Julie Hoover-Fong, Virginia Fano, Juan Lorena, Ravi Savararayan, and Keita Okada. We are also expanding from achondroplasia to consider what other conditions might naturally follow on from the knowledge that we already have. Well, we already said that there are 771 of them. So where should we start? Well, one obvious place to start is when we look at the pathway that is involved in FGFR3 signaling. We see some key players here from other genetic disorders that we have known about for a long time, in particular the RASopathy conditions, as they're called, because when RAS goes wrong, they confer certain genetic conditions that we know as Noonan syndrome and friends. So related to the gene pathogenic variants in the gene that encodes RAS, but also SOS, RAF, and METK as well. So these are obvious starters. And also, what else is going on at the growth plate that we could then start to focus on? Well, Turner syndrome, in which there's SHOX deficiency, because SHOX is a gene that is in the pseudo-autosomal region of the sex chromosomes X and Y. And if you have Turner syndrome, you only have one sex chromosome, so you only have one copy of the SHOX gene producing the SHOX protein, which is important here in the growth plate. So that haploinsufficiency causes short stature, which if you can then improve the growth plate pathophysiology, we'll come on to this anon, then perhaps you have a way to help girls with Turner syndrome grow. And I've already alluded to the fact that type 1 collagen is an important extracellular matrix protein in the cartilage. So another growth plate, a main player in the growth plate. So perhaps too, that could be a target for drugs that act on the cartilaginous growth plate. More of that this evening. So that's me pretty much done. So what I hope I've tried to convey is that that future perspectives where we're going are built upon our past knowledge. What did we find out before? What lessons have we learned before? What pathways did we follow before? And let's see how we can implement them in the future. In spite of all of these innovations and the fancy things that are going on, you cannot get away from the value of history, examination, and investigation, and they remain key. And there is no replacement with these treatments or with future treatments for lifelong multidisciplinary care. And that care may be focused even before birth. And that care, complex as it is supported by consensus guidelines to help keep us on track and do the right thing. A deep understanding of the molecular and protein basis of skeletal dysplasia informs multiple treatment strategies. I showed you a picture of the FGFR3, a ligand trap, a thing that completely blasts the receptor out of the water and a thing that tackles the downstream pathway. But we have other things that we can use, new drugs, repurposed drugs. Lots of different things that could potentially, gene therapies, N-of-1 studies, cell-based therapies, lots of different things that we could potentially bring out of the toolkit to help treat these conditions. But we need to have a deep understanding of the natural history, because then that allows us to not only to target intervention, but also to be able to monitor the outcomes. There was a lot of pain before, there's not so much pain anymore, for example. Skeletal dysplasia, what we're doing here is really an exemplar for all the rare diseases, of which there are 10,000. We mention not one by one, but 771 in this context, but there are 10,000 rare diseases. And what we're doing here in this field is really exemplary for what could be applied to those other rare diseases as well. And with that, I will pass back to Svein to take us on to the next session. Thank you.
Yes, thank you very much, Melita, for this great talk and for explaining to us why the progress that has been made in achondroplasia over the past years can be of benefit to the other skeletal dysplasia conditions. There are one message in the chat. Thank you for this informative presentation. So I fully agree to that. We have a few minutes left for questions if there are any. Please feel free to raise your hand. And...
Hello, Steph. It's nice to see you.
Yeah, it's lovely to be here again, and that was really informative. I know I'm not a doctor, I just sneak into these things and try and keep quiet and never quite manage it, but it was really useful. Thank you so much for letting me join today. I appreciate it.
Absolute pleasure. It's good to have you here.
Yes, thank you.
Are you in London on Saturday?
I'll see you on Saturday.
Any other questions for Melita? Seems like everything was crystal clear, Melita. So thank you again for introducing us to this expansion of related condition. And then it's a pleasure.
Sorry, Sving. I have a question. Is possible?
Yeah, of course. Go on.
Yeah. Hi, Melita. Thank you very much for your presentation.
That sounds like Susanna. Is that Susanna?
Yes.
Hi,
yes,
Susanna.
because I'm connected with the computer of my colleague.
Hi.
It's the physiotherapist.
Hi.
We are together following the conversation. I have a question because it's about the consensus paper, the consensus for the guidelines, for the management for the achondroplasia, the international consensus. Do you think that it will be available with the new treatments? Is available, is useful in a close future, because the new treatment will have a big impact in the development of the achondroplasia?
Yeah.
This consensus will be reviewed in a close future for the new treatments, or what?
Yeah, we will have to review it, you know, we're on the road to acceptance. We've been in denial that we have to do this all over again, but we're on our way to acceptance because it was such a huge piece of work. But yeah, we all agree that this will require reviewing in light of new treatments. I heard today that there are now 3,800 children on vosoritide worldwide. So we are definitely going to need to review this. Any more than that, I don't think we can tell you at this stage. Whether we wait for other things to become available and tackle it all together, probably kick that can down the road. But yes, absolutely, this will require review. Thank you, Susanna, for bringing that up.
And just a comment: you are aware of that there has been published some guidelines, recommendations for the treatment with vosoritide. It was published, I think, in January this year. So this is a kind of meanwhile, while we are looking into reviewing the full international consensus statement. This is a very practical kind of guideline for how to start treatment, monitor treatment, and even stop treatment for infants and children with achondroplasia. So this was published January this year.
Sir, I have a doubt.
Sorry.
Was that a question?
Sir? Yeah, I have a question.
Yeah.
Okay.
What is which treatment is better? Is it vosoritide or infratigrantinib? Which is
well, only vosoritide is approved it's the only drug to be approved, and infigratinib is still in clinical trials. So in respect of which one is a better treatment, we can't say at this stage. We are running clinical trials with infigratinib. Also with TransCon CNP, another form of C-natriuretic peptide. They're both in clinical trials still. Tyra is also developing a treatment for achondroplasia, which will go into clinical trials soon. But at the moment, vosoritide is the only drug that is approved as a treatment. So can't answer that question yet, but watch this space.
okay, because my daughter is 4 months, and so we are just confused whether to go with which one, because I'm basically a surgeon.
Oh, are you? Okay. All right. I don't think we
Yeah.
can discuss that right now. That's probably not within the remit of our meeting today, but you're certainly welcome to follow up with me or one of us separately. That's no problem. The organizers
Yeah.
could put us in touch.
Yes.
Okay, how to like
We'll leave it for there. The
Thank you,
organizers,
Melita.
they'll sort that out. Okay.
And
okay. Thank you very much. Thank you very much.
thank you again. And now it is my great pleasure to introduce the next speaker, who is an expert in a lot of skeletal dysplasia conditions and growth disorders, Dr. Andrew Dauber, Chief of the Endocrinology at Children's National Hospital in Washington, D.C. in the United States. And I think you were the first author on the paper of hypochondroplasia. So we're very excited to have you here to share your experience in treating hypochondroplasia. So please, Andrew, the scene is yours.
Thank you so much. And, thank you to the entire IF for inviting me to give this talk to you today. We're going to go over a number of topics about hypochondroplasia. So this is the outline. We'll start very briefly with the pathophysiology, which Melita has so nicely laid out. We'll talk about what's known about the prevalence of hypochondroplasia, go over its clinical manifestations and comorbidities, spend some time on how you do make the diagnosis, and then talk about treatment options and current trials, and then conclude with a brief discussion of what is needed in the future. So as Melita already explained to us all, the FGFR3 signaling pathway, FGFR3 acts as a brake to growth, and hypochondroplasia, like achondroplasia, is due to activating variants in FGFR3, which then signals downstream through a number of pathways, most prominently this RAS-RAF-MAP kinase pathway, inhibiting growth at the level of the chondrocytes in the growth plate. And as was said in achondroplasia, 99% of the individuals have a single amino acid change. But in hypochondroplasia, there are many different genetic variants that have been associated with causing hypochondroplasia. The most common is this ASN 540 LIS variant. It's been reported between 30 to 70% of individuals with hypochondroplasia have that specific variant. I tend to believe it's towards that higher end of that range. And as pictured here on the right, and as Dr. Irving discussed, hypochondroplasia is part of a spectrum, a clinical range and spectrum of different conditions caused by activating variants in FGFR3. And hypochondroplasia is thought to be the milder end of that spectrum. So what about the prevalence? Well, the truth is that the exact prevalence of hypochondroplasia is unknown. So there have been birth cohort studies. So these are studies where they look across an entire population and look at the rates of diagnoses of disorders at birth. And there have been ones looking at various skeletal dysplasias. And those birth cohort studies estimate that this is a very rare condition, between 0.2 and to 1.3 per 100,000 individuals. Now, this is certainly an underestimate, and that is due to the fact that many children with hypochondroplasia are not diagnosed at birth, right? They're diagnosed, there's a range of ages, but within the first few years, or sometimes even significantly later than that. So the true prevalence must be higher than those estimates. And then if you look in the literature, there are estimates quoted between 1 in 15,000 to 1 in 40,000 individuals. But if you really delve down on where that data comes from, there is not any data that truly supports those numbers. It's really extrapolated from achondroplasia, and we do not know the true rate of hypochondroplasia in the population. So what are the clinical manifestations? Well, first and foremost, hypochondroplasia is a skeletal dysplasia that leads to disproportionate short stature. And similarly, there's a range of clinical severity. And looking at different papers, there are a range of final adult height estimates. So one study from the UK in 1990 estimated adult height for males in a range of 145 to 165 centimeters, so a pretty wide range. Females 133 to 151. There's a paper from Argentina which reports a mean adult height in males of 143.6 centimeters and females of 130.8. And then most recently, mostly out of the UK, Maura Chung and Dr. Irving was part of this effort as well. They created growth charts. We'll go into that in a little more detail, and showed that the height at age 16 years for boys was 148 centimeters is the average, and 139 centimeters for girls, representing -3.3 and -3.9 standard deviations on the UK average stature growth charts. And these were not final adult heights, because they did not have final adult height available from the way the methodology was, so perhaps slightly taller at final adult height. But you'll see that the population from Argentina is likely slightly shorter than the population from the UK, which might also have to do with the underlying genetic background of those individuals. As you know, somebody's height is not solely determined by the one variant in FGFR3. So in addition to disproportionate short stature, patients routinely have relative macrocephaly. They don't actually have, it's rare to have frank macrocephaly, meaning that the head circumference is rarely above the 95th percentile for the general population, but relative to their short stature, the head is definitely significantly larger. So here's an example of the hypochondroplasia specific growth charts. Pictured here, I'm taking a measurement of one of my patients in a clinical trial for hypochondroplasia. And you can see this is the male growth charts from age 0 to 16 with height and head circumference. On the left, if you look at the height growth charts, the multiple colors are the percentiles for individuals with hypochondroplasia, and the gray lines are the UK growth chart behind that. And you can see that very early on, before age 1, there's much more overlap between the populations. And after age 1 to 2, I would say there's much more deviation. But there is overlap with individuals with hypochondroplasia, at times having heights above the 3rd or 5th percentile of the average stature population. And on the right, for the head circumference, you see there's a lot more overlap, and only the individuals with the largest head circumference are really, frankly, macrocephalic. Now, these growth charts were developed from 188 children from 18 different centers. Of those 188 children, only 77 were genetically confirmed to have hypochondroplasia. So we'll talk a little bit more about whether that may be important and how representative is this data. Okay, and here's pictured another patient that I'm doing a sitting height measurement on to look at body disproportion. And pictured here on the left is from that Argentinian paper, are the sitting height to standing height curves, which is a measure of body disproportion. And what you see in the lower lines are the sitting height ratio, as it's called, of the average population. And the individuals with hypochondroplasia have very elevated sitting height ratios, which means that their trunk is proportionally much longer than their limbs, as they have short limbs, leading to that body disproportion. I will tell you, though, after seeing many patients, not all patients with hypochondroplasia have such severe disproportion. There are some who is much milder, but I have yet to find a patient who, with careful measurement, does not show some evidence of disproportion compared to the average statured population. Okay, so there are additionally medical comorbidities in the neurological domain, and I'm going to divide this into clinical side and radiologic side. On the clinical side, there have been a wide range of neurocognitive defects reported, and the prevalence of these differences, I would say, ranges in the literature from 0 to 75%. So really wide range there. Patients with mild learning disabilities to severe defects. And there's definitely a higher rate of the diagnosis of ADHD. It's not clear that that's the right diagnosis, but there's clearly an increased incidence of attentional issues in individuals with hypochondroplasia. Now, I do not think the true prevalence of these, either of the ADHD or of the neurocognitive defects is well known, because the prevalence estimates really vary widely based on the design of the cohort, right? So some of these reports are from neurologist's office or from individuals who have undergone neuroimaging for some reason. And those patients may be skewed to have higher rates of neurocognitive effects, as compared to if we really did a more population-based study. And the same thing is true with the seizure diagnosis. So seizures are associated with hypochondroplasia, but again, the prevalence of seizures in hypochondroplasia in the reports range from 0 to 50%. And these are all relatively small cohorts that have been described. And the types of seizures can be quite variable. They often begin in infancy, and they can present just as apneic spells, as lip smacking, or some unusual movements. They can have complex partial seizures with focal movements and even generalized. But the majority of patients, as I said, present in infancy. Majority that I've seen have been well controlled, most of them taking Keppra. And the seizures seem to resolve on their own within the first few years of life and then are not an ongoing issue. However, there definitely have been individuals reported in the literature who have refractory epilepsy, unresponsive to treatment, and individuals who have persistent epilepsy into adulthood. My personal feeling is that epilepsy seizures was probably present in around 5% of children, maybe in that 5 to 10%, range. But I think there's some children who this does go undiagnosed in infancy due to the kind of atypical nature of some of the seizures. Now, on the neuroimaging front, the most common finding reported is temporal lobe dysgenesis, which is pictured in the MRI on the bottom. I am not a neuroradiologist, so I would just look at where those white arrows are, and apparently that is not normal. But in addition to the temporal lobe dysgenesis, there are other findings that have been reported in children with hypochondroplasia, including corpus callosum abnormalities, hydrocephalus, abnormally shaped ventricles, and others. And Dr. Maura Chung, I think, is going to be presenting some updated information on this at the upcoming ESPE conference. So stay tuned. I look forward to hearing her research presented. But in one study, for example, from Korea, there were 12 patients with that N540K variant who underwent neuroimaging, and none of them reported to have temporal lobe dysgenesis, but they did have 42% had some other type of neuroimaging abnormality. And it's not really well known. The temporal lobe dysgenesis is thought to be the root cause of some of the epilepsy, which follows that pattern. But not everyone necessarily with the MRI finding presents with clinical signs of seizures. So we don't really know the full clinical implications of these radiologic findings. Okay, what about other comorbidities? Well, there really have not been comprehensive studies of medical comorbidities in a cohort of children with hypochondroplasia. So from my experience, some things that definitely come up is there is an increased risk of tibial bowing and genu varum, most of which does not need any intervention and seems to not lead to significant medical issues. There seem to be higher rates of ear infections and sleep apnea in this population. There was one study that has only been presented in abstract and poster form. So Dr. Irving was one of the authors on this. This was done with the team at BioMarin. And this was a population-based kind of study looking at a healthcare database. And they identified 610 individuals in the UK with diagnostic codes consistent with hypochondroplasia. They compared them 4-to-1 to controls, and they found, I just highlighted some of the findings here, that in children under age 16 with hypochondroplasia, ear, nose, and throat, respiratory, orthopedic, and neurologic events were all statistically more common than the general population. There's a higher surgical burden throughout the life in certain areas associated with that. So for example, limb surgery, joint replacement, hearing implants, spinal surgery, and tonsillectomy and adenoidectomy. So it does seem that individuals with hypochondroplasia do have some of the comorbidities that are seen in individuals with achondroplasia as well, but likely at a much lower rate. But really, the natural history of this, when they occur, whether it's in childhood or adulthood, has not been well delineated as of yet. Now, what about quality of life? Well, I recently did a PubMed search for quality of life and hypochondroplasia, and a total of 3 papers show up in PubMed. 2 of them are adult papers where hypochondroplasia is included in a group with achondroplasia. And those 2 papers include a total of 7 individuals with hypochondroplasia. And there are no analyses or reporting of the individual results for the patients with hypochondroplasia. They're just, grouped in with the patients with achondroplasia. So really, it's very hard to say what is the specific impact of hypochondroplasia on quality of life, especially in adults. There is one pediatric study, which is my group's study, where we, as you'll hear a little bit later in my talk, we are doing a phase 2 study of vosoritide in a number of different genetic conditions, pictured here, including hypochondroplasia. And we did a questionnaire called the QoLISI, which stands for Quality of Life in Short-Statured Youth. And the reference population that this was developed in are patients with idiopathic short stature and growth hormone deficiency. They're in that light purple. The patients with hypochondroplasia are in that red-orange color. And you can see that the individuals with hypochondroplasia had lower quality of life, especially in the physical domain, compared to that reference population. And some of this might be reflective of the severity of short stature. We don't really know much about the severity of short stature in the reference population. But you can see some of the other genetic subgroups in our cohort had even lower scores as well. So our group and others are now also doing some qualitative studies to try and get kind of a better understanding of the impact on quality of life in individuals with hypochondroplasia. So I think we're going to see a lot more data come out about this area in the near future. So looking forward to that. Okay, so what about the diagnosis of hypochondroplasia? Because there are, as opposed to achondroplasia, there are no consensus guidelines about the diagnosis or management of hypochondroplasia. So I'm going to quote from Gene Reviews. This was written by Dr. Bober and some of his colleagues. I see that he's on the call today. So this is, I think, what a lot of people refer to for guidance. And to quote, it says, the clinical and radiologic diagnostic criteria for hypochondroplasia remain controversial for several reasons, including the following. So 1, there is no single radiologic or clinical feature unique to hypochondroplasia. The expression of many of the established diagnostic features in affected individuals is variable. And finally, locus heterogeneity has been established. That means that there can be genetic variants in different genes that can have similar presentations to hypochondroplasia. Second, according to this article, it is clear that a complete radiographic survey, including skull, pelvis, AP and lateral spine, legs, arms, and hands, is absolutely necessary to make a clinical diagnosis of hypochondroplasia. So I personally do not agree with that, and I think that we could spend a lot of time debating how much you need the radiologic criteria versus clinical criteria to meet, the diagnosis of hypochondroplasia. But on the right side, you can see there's a long list of features that are characteristic of hypochondroplasia, such as the short stature, the disproportion, limited elbow extension, and so on. Radiologic features, one of the most characteristic is the narrowing of the inferior lumbar interpedicular distances, or a failure of those to widen. And there's this list that you can refer to see, what are likely features in hypochondroplasia. But I wanted to pose a few thought questions for us to ponder and maybe to discuss later. So what is the role of genetics and in the diagnosis? So is a genetic variant in FGFR3 absolutely necessary for the diagnosis of hypochondroplasia. So let's say you have a child who has all of those clinical features and you comprehensively sequence FGFR3 and you cannot find a variant in FGFR3. Do they still have hypochondroplasia? On the flip side, let's say, is the presence of a known pathogenic variant in FGFR3 sufficient for the diagnosis of hypochondroplasia? So let's say you have a clear pathogenic variant, and I've seen patients like this who are not sure, right? Who have the variant, but they're at the 10th percentile in the average stature growth chart, or they only have extremely mild body disproportion, or they don't have the X-ray findings. Do those individuals still have hypochondroplasia? And based on your answers to this question, how do those answers affect your decision to treat with a targeted therapy? If somebody doesn't have a variant in FGFR3, can you still use a medication which targets FGFR3 to try and treat their clinical syndrome? Or vice versa, if they have short stature, what looks like isolated short stature without all the clinical features, but have a pathogenic variant in FGFR3, but are not diagnosed with hypochondroplasia, could you still treat them with a targeted therapy? So much to ponder. Okay, and it is an important question because genotype may influence the clinical presentation. So I'm going to show you a few studies on that topic. So this is an interesting study. This was a study from 1998 of a cohort of 65 children clinically diagnosed with hypochondroplasia at the Great Ormond Street Hospital. So some of you may have worked at this institution. This is a very well-renowned institution. I'm going to presume that the authors of the study knew what they were talking about when they diagnosed patients with hypochondroplasia. So what they did was they divided their study into 3 groups. So one group was patients with achondroplasia. They had 18 patients with achondroplasia as a comparison. And then the 65 patients with hypochondroplasia were divided into 2 groups. So group 2 in this graph is 28 patients who have the classic N540K variant in FGFR3. And group 3 are patients where they sequenced the FGFR3 gene and they did not find any variant in that gene, albeit with whatever technology they were using in 1998. However, they required that in order to be in the study, all patients had to have that classic finding of a decreased lumbar interpparticular distance. And what you look is the graph mentions their total height standard deviation. Then it mentions their sitting height and then their subischal leg length. And what you can see is the individuals with achondroplasia have significant short stature, and their sitting height is not as affected, so they have significant body disproportion. In group 2, the patients with the N540K variant, they have milder short stature compared to achondroplasia, but they also have evidence of disproportion, while the patients who were genotype negative did not have a significant disproportion, showing that despite these patients being clinically diagnosed by an expert group as hypochondroplasia, there was a difference in their clinical phenotype. 2 more studies to consider. So this study on the left is from Korea. This was another group where they had been referred 160 patients for a concern of hypochondroplasia. They then used not the exact same criteria, but they used their own clinical and radiologic criteria that they thought were kind of very definitive for having hypochondroplasia. And they said, okay, we think 58 of these patients have hypochondroplasia. They then tested them for both the FGFR3 and SHOX gene. So first of all, of the 58, only 19 had a variant in FGFR3. So that's 33%, 1/3 of them. And then of the negative patients, 39 of those, 6 of them ended up having pathologic mutations in the SHOX gene. Okay, arguing that this is that locus heterogeneity idea, arguing that they're patients with SHOX gene mutations who may be clinically diagnosed as hypochondroplasia. All right, now on the right, let's fast forward. This is a table from the recent UK hypochondroplasia growth chart paper. So as I said, not all of those patients were genetically confirmed. Of the 188 patients, only 84, so 45% had genetic testing. Of those 84, 77, 92% had an FGFR3 variant, right? That's very different from the Korean study, right? In the Korean study, 33% have have a mutation in FGFR3. In the UK, 92% of those tested had an FGFR3 variant. And of those, 48% were the N540K, but there's a group that were just listed as positive, so it could be up to 70% with that N540K variant. And I just also wanted to show you this table because I think it just nicely illustrates that there really is a wide spectrum of different genetic variants that have been associated with hypochondroplasia in FGFR3. Okay, so to sum before we get on to treatment, hypochondroplasia, in my opinion, is a condition marked by disproportionate short stature due to activating variants in FGFR3, but we do not have a consensus guideline on the diagnosis or management, and there really is a very wide clinical spectrum. And I'm happy to announce that in collaboration with the IAF, we are going to be working on developing those consensus guidelines. Time frame not known quite yet, so we got some time, but we'll come back to you in the coming years, hopefully with more on those guidelines. Okay, so let's move on to treatment. So starting out with growth hormone, there have been numerous studies of growth hormone in children with hypochondroplasia. None of them are randomized, controlled, long-term trials of growth hormone therapy. So I'm not going to go through all of them. I just wanted to highlight a few to show some kind of variability in the data. So first, there was a study, this very interesting study, of discontinuous high-dose growth hormone. So it's very high dose, but I think it was like every 2 years, they took a break, a pause of growth hormone for at least a month or so. I don't remember the exact details, but in 6 patients, and they were followed for a course of 6 years. In these 6 patients, their average height standard deviation increased from -3 to -1.1. Quite a marked response. And they state that their body proportions improved. Unfortunately, we don't have any final height data on these patients. I contacted one of the authors, and they said that they never published yet final height data on these patients. Now, on the flip side, another study of 19 patients who were treated for 3 years, their height standard deviation increased 0.62 over the 3 years, with 0.42 of it being in the first year. So they saw more of an increase in the first year and then really not much more in the second and third year. And they reported worsening body disproportion as well as significant insulin resistance during growth hormone treatment. And in the children who were pubertal already, they saw no improvement in their height standard deviation. So really kind of a different perspective. And there's been a meta-analysis to look at a total of 7 studies with 113 different children treated with growth hormone. And you can see here the results were pretty similar to the Pinto study. At 1 year, there was an increase on average of 0.41 standard deviations. And there was, again, a slight improvement over the next 2 years, but really a wide variability in response and very little data past 36 months. So as a result, growth hormone is not approved for hypochondroplasia in the United States or in Europe. It's not really in widespread use in those areas. It is approved for use in Japan at the dose listed on the slide. So could there be a role or some component for growth hormone in hypochondroplasia? I don't know. Could there be some combination therapies? Possibly, but it's not a highly efficacious treatment, at least in most studies. Okay, oops. So what other therapies are in trial? I'm not going to belabor this point because Melita really beautifully went through these mechanisms. So there's infigratinib, which is the direct tyrosine kinase inhibitor, which kind of cuts the power to the brakes, I like to think about it. So FGFR3 is no longer sending those signals. And then there are CNP analogs, vosoritide and TransCon CNP or nabipagratide, which acts like CNP, and they work downstream, lifting up the brake in that RAS, RAF, MEK, MAP kinase pathway. So what are the status of these trials? So this is all based on the public information. So for infigratinib, this is from the QED website. you see there is the Excel program, an observational study, which will then be followed by a phase 2 and phase 3, currently in the phase 2 part of this program, and look forward to starting to hear results and see that in the coming year or two. And then for Ascendus, this is from one of their slide decks on their website. I've circled for you, it says that there is a plan to submit an IND or similar for the treatment of hypochondroplasia in Q4 of 2024. So 2025, excuse me. So no ongoing studies yet for TransCon CNP, but hopefully those will be launching within the next year. So more to come once we hear more details on that. So the only data that we have right now is with vosoritide. So this is the design of the phase 2 study that my group ran, and the results for hypochondroplasia have now been published last year in eClinical Medicine. So children between the ages of 3 and 11 for boys, 10 for girls, with short stature. They had a 6-month observation period and then a year of treatment using the same dose of vosoritide that was used in the achondroplasia studies. And then there's a long-term extension study. We looked at safety, we looked at measures of efficacy, body proportions, bone age advancement, and then some exploratory study endpoints as well. So this is the entire study cohort. There were 26 patients with hypochondroplasia, 12 with aggrecan, 8 with Noonan, 7 with NPR2 mutations, 2 with neurofibromatosis type 1, and 1 with Costello syndrome. And I'm only going to focus on the patients with hypochondroplasia today. So this has all been published. You can read details of this. There were 27 patients screened, 1 of whom was too tall. And then of the 26, 2 dropped out during the observation phase of the trial. The travel was just too much for them, and 24 patients completed the entire year of therapy. You can see on the right their demographics. The average age was just under 6, with 10 patients being between 3 and 5, 11 patients between 5 and 9, and 3 between 9 and 11, half male, half female. And 22 of the 24 patients had the ASN 540 LIS variant. So in terms of safety, the safety profile very similar to what's been reported in children with achondroplasia. It's very common to have mild injection site reactions, all of which self-resolved without intervention. Nobody discontinued treatment due to an adverse event. There was 1 serious adverse event, which was unrelated to vosoritide when child developed a viral-induced ITP. There was 1 episode of syncope after the first injection, actually, but the patient had a normal blood pressure at the time. She had also just gotten her IV placed and blood draw, and she went on to take the medicine for the year without any further incidents, and no episodes of symptomatic hypotension. So what about the efficacy? So these are the graphs of the growth velocities. So you see that from the observation period to month 12, there was a 1.81 centimeter increase in the annualized growth velocity, which correlated to a 2.26 standard deviation increase in growth velocity Z-score. So very, I would say, similar results to what was seen in achondroplasia, maybe slightly better. If you want, you can peruse all of the individual curves online. This just shows that there was definitely significant variability in response between patients. When we tried to drill down and see what were predictors of response, really the biggest thing that came out was that patients who had the lower baseline growth velocity had more of an improvement in their growth rate compared to those who started out growing at a faster growth rate. People had improvements in growth velocity irrespective of their baseline height standard deviation score. So this looks at the change in the height standard deviation score based on the CDC growth curves. You can see that from screening to day 1, there was no improvement, which makes sense. The patients were not getting any medication. But then from day 1 to month 12, there was around a 0.37 standard deviation increase. So very similar to what was reported in those first year of the growth hormone treatment trials. And if you look at the hypochondroplasia specific growth charts, you see a similar 0.4 standard deviation change over the course of the year. And of course, these patients are, fall closer to the middle of the hypochondroplasia growth charts. They're a little bit below average for patients with hypochondroplasia starting out. We looked at some biomarkers as well. So on the left here is the collagen 10 biomarker. This is a biomarker of endochondral ossification, bone growth. And what you can see is, again, during this, from screening to day 1, during that observation phase, no change. And then there's a robust, almost doubling of the CXM biomarker as the patient's growth velocity improves. And on the right is the urine cGMP, which is an acute biomarker of CNP signaling, showing a robust increase in signaling with vosoritide, which is sustained overall throughout the year of the trial. There was no change in the bone age to chronological age ratio, so no premature advancement of bone age. In terms of body disproportion, the sitting height ratio did minorly decrease in absolute numbers over the course of 1 year of treatment, but when adjusted for age and sex, there was no significant change. Now, it's only been a year. Often that can take a number of years to see a statistically significant improvement. No change in the arm span minus height, and no change in parent-reported quality of life based on this one questionnaire over the course of 1 year. We published the pharmacokinetic studies as well. Just to sum up, the pharmacokinetics were very similar to what has been reported for achondroplasia, which would argue for similar dosing. And then we looked to see whether the pharmacokinetic exposure was related to the growth outcomes at all, and there was no statistically significant correlation between, here on the x-axis, you have the area under the curve of the pharmacokinetics, versus on the y-axis, you have the change in the height velocity or height standard deviation. So it was not clear that kids who grew faster just were being exposed to more drug. Okay, so where do we stand right now? Well, BioMarin is now conducting a phase 3 trial of vosoritide for hypochondroplasia. This is a double-blind, placebo-controlled trial. I'm an investigator in the trial, as are, I think, others on this call. A total of 80 subjects. According to clinicaltrials.gov, this study started on June 6th, 2024, and they estimate having a completion date of August 2026. So a little bit more than a year, and hopefully we should have results to report from that trial as well. All right, so to sum up and look towards the future, what do we still need for individuals with hypochondroplasia? Well, first, as I mentioned, we really need a better understanding of the true prevalence. Hopefully there's some studies out there that are, I think, starting to get at that. We need to really understand the natural history, including rates of comorbidities and better quality of life data. There needs to be deeper research into the neurocognitive profiles and correlate that with anatomic changes in patients with hypochondroplasia. We need to develop consensus guidelines on the healthcare supervision of children with hypochondroplasia. There's wide variability in how much testing these children get, and I think we need to make sure they're getting the care that they need, but not excessive medical care either. And finally, we need to get to the point where we have approved effective medications for children with hypochondroplasia. And I think there are a few comments in the chat maybe before we get to the break.
Yes, would you like to comment on that, Andrew? Thank you for a great talk.
Sure, so let's see. So Dr. Bacalio mentioned that the variable expressivity in hypochondroplasia makes it important to confirm the clinical diagnosis with molecular testing, especially for milder forms. So I tend to agree with you, Philippe, but I think that will be part of the conversation when we get to the consensus guidelines, hopefully. Great, so then there was a question from Pete Constantino, excuse me if I mispronounce your name. Were the cohorts in the growth hormone studies comparable, e.g. for failure of widening of IPD? That's a great question. The answer is no. They were not all. So I've read through these studies, and I don't remember all the inclusion criteria, but they were not all the same, right? So some of the studies only had genetically confirmed patients, some did not. and they each had their own kind of criteria for how patients were clinically diagnosed with hypochondroplasia. Some of these are quite old studies as well. So it is, it's hard to say for, it's hard to say for sure. You mentioned also for defining cohorts for trials going forward from the trials that I've seen, and these are the inclusion criteria, I believe, are on clinicaltrials.gov. They are requiring a genetic diagnosis in the current clinical trial. So in the infigratinib trial and the vosoritide trial both do require a genetic diagnosis, but they do have differences in their inclusion criteria, which we probably can't get into right now. Okay, and then this is a very interesting question about whether there's a consistent, distinct DNA methylation signature for achondroplasia, which...
And whether you might be able to leverage that. I mean, I'm coming from this as a geneticist in the UK. It was a lovely talk, by the way. Thank you. But there's with a lot of the forms of molecular testing that Melita had talked about in her excellent talk before. One thing that we are using a little bit nowadays when we're not able to make a diagnosis or when we find a variant of uncertain significance is looking at the episignature, the methylation around the DNA, because there are some disorders where there is a signature which is consistent among individuals with that particular condition. Now, I don't know with the molecular basis of achondroplasia, hypochondroplasia, with it being the gain of function in the pathway, it might be that there is no methylation signature. But I just wonder if anyone has looked at that and whether that might be something you could leverage to look at particularly those gene negative hypochondroplasia patients, because it might help to distinguish between different underlying mechanisms and iron out those cohorts a little bit. I don't know. It's just a thought.
No, that's a great and fascinating idea. I'll just, for hypochondroplasia, I have not seen any methylation signature data done. And Melita, I don't know if you want to speak to achondroplasia.
Yeah, Pete, that's a really great concept, and one that, full disclosure, we have not thought about before.
Yeah.
But yeah, there remains some unexplained molecular background to hypochondroplasia. So maybe let's talk about that sometime to see if we can explore that. Maybe we can do it down there with you guys.
Or in a couple of weeks.
We should talk about that because it's a good idea. We should think about how to do that.
Thank you,
Right,
Pete.
cheers.
Nice to see
Thank you. Thank you
Nice
so
to see
much,
you.
Andrew. And thank you for those who are coming with commenting in the chat. We will please continue to ask questions to the presenters, and we will have some time at the end of all presentations to come back to some of these questions. So thanks again, Andrew. That was a great presentation. I think we now have 15 minutes for break, so please be back 15:15, and we will have the next talk then by Philip Bacaleu about treating Noonan, Turner, and shocks. So 15 minutes break, and see you in 15 minutes. Thank you. So welcome back to this next session, and thanks again to Melita and Andrew for great talks. Now it is my great pleasure to introduce the next speaker, Philip Bacaleu, who is a pediatric endocrinologist at Cincinnati Children's Hospital Medical Center in the United States. And he's also an expert in growth disorders, and he will share his knowledge about treating Noonan, Turner, and shocks. So please, Philip, this floor is yours.
Oh, well, thank you, Svein, for your introduction, and thanks to the IAF steering committee for giving me the opportunity to participate in this workshop and be part of the discussion. As you can see from my title, in the next 20-25 minutes, my goal is to make some general comments regarding the treatment of 3 different conditions: Turner syndrome, shocks deficiency, and Noonan syndrome. So I have some disclosure included on this slide, and I have 3 objectives for this talk specifically. I'll first review in a general way some of the current management aspects and treatment options for individuals with Turner syndrome, SHOX deficiency, and Noonan syndrome. I'll then discuss some of the challenges that we encounter in clinical practice with respect to making a correct diagnosis and relatively timely diagnosis, as well as some aspects of the therapeutic interventions in these patients with these three conditions. And then I'll finish up by discussing a little bit the therapeutic pipeline for these three conditions and the potential for these novel drugs to improve the outcome, specifically for their associated comorbidity of short stature, but possibly also for some of the related other organ system comorbidities. So let's start with Turner syndrome. We all know that this is a relatively common condition that affects females. Its prevalence is about 1 in 2,000 to 1 in 2,500 live-born females. And the condition is due to a total or a partial loss of one of the X chromosomes and can present as 45X monosomy, but often presents also in a form of mosaicism. Turner syndrome is universally associated with short stature. And then the other clinical features that affect a variety of organ system comorbidities can be present in different ways. And the clinical features are quite variable throughout the entire Turner syndrome population. The short stature in Turner syndrome is attributed to a specific form of mesomelic skeletal dysplasia that is associated further with some disproportionality. As you can see in the figure on the left from paper from Klaus Grafholt from Denmark, the different body proportions in Turner syndrome sort of confirm this mesomelic form of skeletal dysplasia with relatively short extremities. And the short stature that is characteristic of Turner syndrome is also associated with a variety of other skeletal abnormalities. Now, the growth failure in Turner syndrome is due, as Melita already alluded to, by a deficiency of the SHOX gene. The SHOX gene lies on the pseudoautosomal region of the short arm of the X and Y chromosomes. It lies on XP22.3 for the X chromosome, and it encodes a homeodomain transcription factor. Normally, SHOX does not undergo X inactivation, and therefore 2 copies are required for a normal situation. And of course, in Turner syndrome, 1 is missing, leading to the short stature profile associated with some other skeletal features. You can see that Turner syndrome short stature gets further developed in the postnatal age range, but many girls with Turner syndrome already present with a mild degree of intrauterine growth retardation. And on average, the birth length and birth weight are about 1 standard deviation below the mean for the general population. There is further also slow growth in infancy and toddler age, and it can be further accentuated by nutritional issues and feeding problems. There's definitely also suboptimal childhood growth, and many girls also have an absence of the pubertal growth spurt. And these different periods of suboptimal growth all lead to a loss in adult height outcome of about 20 centimeters or 8 inches compared to what the height should be based on the patient's peers or the genetic target height that they should grow towards. So for several decades, the only available treatment for these individuals' growth failure has been the daily use of somatropin, or recombinant human growth hormone, administered subcutaneously. And you can see from the figure on the left, which is the North America placebo-controlled trial, that the mean adult height gain in these girls compared to placebo controls is about 5 to 7 centimeters over a period of about 5 to 8 years of treatment. So I think it's a fair statement to counsel families that they can expect about 1 centimeter of height gain per year of treatment. But there are other factors that will determine the treatment outcome. For example, the dose of growth hormone use is very important, and the right upper figure shows you the result of the Dutch dose response trial, which was an observational trial in which several doses of growth hormone were used until adult height. And you can see with about a 50% dose increase, of growth hormone, you get a little bit of a better height gain at adult height. And most girls with Turner syndrome end up within the normal range for the height standard deviation score here. The other thing that can affect the treatment outcome is when patients are started earlier on treatment. And in the right lower figure, you see the results of the toddler Turner syndrome trial, which was led by Marcia Davenport. And it shows that with early institution of treatment, you get a good treatment response with a normalization of the height, and a height difference between the treated group and the untreated controls was about 1.6 standard deviations already after 2 years. So based on the results of these studies, the consensus meeting for Turner syndrome, which made an update for the clinical recommendations, and which was published in 2024, came forward with a number of updates on the recommendations for how growth hormone therapy should be applied in Turner syndrome individuals. And so we currently recommend that growth hormone treatment should be started early in these girls, and early means from as young as 2 years of age. And we suggest that growth hormone therapy should be continued until little growth potential remains, and that usually means that the girls have reached the skeletal age, bone age maturity of about 14 years of age, or when the patient's height velocity has dropped to below 2 centimeters per year. The recommendations in most regions of the world where growth hormone therapy for Turner syndrome has been approved is to use a growth hormone dose of 45 to 50 micrograms per kilogram per day, but this can be titrated up to about 67, 68 micrograms per kilogram per day, and may be necessary if the treatment response is somewhat suboptimal after the first 1 to 2 years, or if the adult height is severely compromised because of having short parents, or, for example, a late diagnosis of Turner syndrome. That all being said, the adult height that is attained tends to be at best in the lower range of the in the lower area of the reference range, meaning that the overall treatment response for these girls' growth failures is somewhat subpar. And my slides do not advance. There we go. So for SHOX deficiency, we can make a couple of similar conclusions. SHOX deficiency will also lead to short stature, but is due to specific pathogenic variants of the SHOX gene. It can be due to a deletion, duplication, or insertion that involves the SHOX coding gene, but also may involve the enhancer region. And the classical type, the classical type of SHOX deficiency is a form of skeletal dysplasia, which we know under the term Leary-Weill dyschondrosteosis. These patients are characterized by short stature, mesomelia, and they may have other skeletal abnormalities, including Madeline deformity, bowing of the knees, and they may also have scoliosis issues. So this is the classic form of SHOX haploinsufficiency, but the number of patients with SHOX deficiency really demonstrate a very variable phenotype, and some of these patients may have little to no clinical features on physical exam, and their disproportionality may also not be noticeable. And so we call these patients as having a non-specific form of short stature, and previously We would call these individuals as part of the group, the heterogeneous basket of patients labeled idiopathic short stature. And it's been found in a number of reports, a number of studies, that about 2 to 3% of individuals with idiopathic short stature may have their short stature due to SHOX haploinsufficiency. Different from Léry-Weill and different from non-specific short stature due to SHOX deficiency is Langer-mesomelic dysplasia, which is a severe form of skeletal dysplasia that is due to homozygous or compound heterozygous SHOX pathogenic variants. So today we're talking mainly of patients with milder forms of skeletal dysplasia due to SHOX deficiency. And the treatment recommendations for daily growth hormone therapy in these patients is fairly similar to what's been recommended for Turner syndrome individuals. That is daily somatropin therapy at a dose of about 50 micrograms per kilogram per day. And we can also expect a gain in adult height that is about 3 to 4 inches or 7 to 10 centimeters. You have difficulty advancing the slides. There we go. So, and here I'm showing you some data from a fairly recent study that looked at the efficacy of daily somatropin therapy in individuals with SHOX deficiency. And you can see that the improvement in height velocity and the improvement in the height standard deviation score occurs mainly in the first 12 to 18 months of treatment. And afterwards, there is an attenuation of the growth response. And this is somewhat similar to what we observe in individuals with Turner syndrome. And then finally, for Noonan syndrome, this is different, of course, from Turner syndrome and SHOX deficiency individuals with respect to the underlying etiology. Individuals with Noonan syndrome have a genetic condition that is characterized with distinct facial characteristics, and these can change with age. And it can actually be quite difficult to elucidate or to ascertain some of these typical characteristics in the newborn or infancy age range. And so this is one of the reasons why diagnosis also in Noonan syndrome can be delayed. They're also characterized by a variety of other organ system problems, including congenital heart disease that may include pulmonic valve stenosis and hypertrophic cardiomyopathy, with a prevalence that differs based on the genotype of the individual. You can see on the right how the growth curves of Noonan-specific growth curves of boys and girls with this condition overlap the 5th, 50th, and 95th percentile for the general population. And so we can see that growth failure and ensuing short stature occurs in about 50 to 70% of individuals with Noonan syndrome. And different mechanisms for their poor growth have been proposed, including a certain degree of growth hormone insensitivity, specifically in patients who may have as a genotype a PTPN11 variant. But more and more, most Noonan syndrome patients seem to have their growth affected by a defect in the RAS/MAP kinase pathway, affecting growth at the growth plate level. Now, Noonan syndrome is one of multiple rhizopathies, and a rhizopathy being a disorder of the RAS/MAP kinase pathway, an important intracellular signaling cascade that's essential for cell proliferation, differentiation, and survival. And the short stature is characteristic for a number of rhizopathies. For example, not just Noonan syndrome, where it is a salient feature in the majority of patients, but also cutaneous syndrome as well as Costello syndrome are characterized by having short stature. And the table on the bottom shows you the different rhizopathies besides Noonan syndrome and their respective underlying genes that are affected by pathogenic variants that lead to the clinical condition. And just as for Turner syndrome and SHOX deficiency, the treatment that we have employed for the last 2 decades for Noonan syndrome individuals also consists of daily treatment with somatropin, recombinant human growth hormone. And again, the best response is seen early in treatment. A better response seems to improve the near adult height outcome. And a recent study shown here on the right actually looked at PTP-N11 positive versus PTP-N11 negative patients, and they actually saw no difference with the treatment of daily somatropin over a 4-year period, sort of arguing somewhat against the growth hormone insensitivity explanation. So what we have seen from these, just a brief description of the treatment response in these 3 conditions, is that the overall treatment response is somewhat subpar. Definitely less as what we are used to see in growth hormone deficient individual treated with recombinant human growth hormone. And so what are some of the overall challenges of short stature treatment that are common to these 3 conditions? Well, first of all, and I've mentioned this already, is that both Turner syndrome as well as SHOX deficiency patients, as well as Noonan syndrome patients, may be diagnosed late. For example, in Turner individuals, when the diagnosis is not made prenatally or in the first year of life, it is quite common that the diagnosis is only made at the end of the childhood age range. And sometimes diagnosis is delayed until the 2nd decade of life when puberty is delayed, for example, in Turner individuals. And late diagnosis means late institution of treatment and less good adult height outcome. There is also, and it's applicable to the 3 different conditions, a poor genotype-phenotype association. And for example, we know that SHOX haploinsufficiency can lead to a classic form of skeletal dysplasia, Léry-Weill chondrosteosis, with obvious disproportionality, but it can also present with just a thrust form of just isolated short stature. And in Turner syndrome, girls with 45X monosomy can grow very well, whereas girls who have mosaicism for a 46XX cell line may have very poor growth. With growth hormone therapy, we're also not treating the underlying pathophysiology. These individuals tend not to be growth hormone deficient and at most may have a relative resistance to the growth hormone IGF-1 axis physiology at the growth plate level. But we're really not treating the underlying pathophysiology with daily somatropin therapy. Then there's the issue of suboptimal treatment adherence and even below desirable treatment persistence, meaning treatment in the long term. Because the growth response in these individuals is less than what we usually expect to see in growth hormone deficient individuals, sometimes how we counsel the patients may give the impression to the caregivers, to the parents, that a really good treatment response is to be expected. And then sometimes the treatment response in the first couple of years is below par and below expectations, and that may also negatively affect long-term treatment adherence. Then there's the dosing issues. Even though for these disorders, there's a range of doses that we can prescribe for these patients, many physicians do not titrate the doses, even if they see sort of a suboptimal response after 1 to 2 years in their patients. And finally, as you can see here on the figure on the right bottom, this is a study from Peter Bank from quite a number of years ago already, where we looked at the first-year growth response in a number of disorders, and it didn't really matter how you defined a poor response. Many patients with Turner syndrome, anywhere from 20 to 40% had a suboptimal response, and also patients with skeletal dysplasias and patients with Noonan syndrome were included in this study. So many of these patients are poor responders, even from the first 1 to 2 years of treatment. Next slide. So then, of course, we've now sort of pointed out what sort of the challenges are and what are some of the potential novel treatment interventions that are being introduced or have been introduced for these individuals. And so one of the novel treatments that has been in the center of attention in the last couple of years is the introduction of long-acting growth hormone preparations, which by definition, since they're given on the currently approved drugs on a weekly basis, will lead to about 85% fewer injections on an annual basis compared to daily somatropin therapy. And despite the fact that the long-acting growth hormone preparations seem to be based on the phase 3 trials and some of the initial long-term extension trials seem to be non-inferior to the treatment with daily somatropin and having also a similar safety profile, which is quite benign. These are larger molecules that have potential issues with regards to treatment efficacy long-term as well as monitoring. The large molecules may not always reach their target tissues in an optimal fashion, depending on their molecular size. There are also different requirements for monitoring patients on long-acting growth hormone therapy with respect to the measurement of IGF-1 concentrations. And it still needs to be proven that despite the fewer injections on an annual basis, that long-term adherence will be good enough to improve the treatment outcome. And on the right, I'm showing you some data from a study in China that looked at a couple of doses of a long-acting growth hormone preparation and compared that with daily growth hormone treated group in green. And this is an area here. The purple bars are the untreated control patients, and this is in Turner syndrome. And you can see that the delta height SDS and the height velocity improved in the patients treated with long-acting growth hormone as compared to the untreated controls, and was quite comparable to the patients treated with daily growth hormone therapy. Next slide. All right. What about some of the other potential novel interventions, which have already been touched upon earlier today? Well, if we look at how growth is impaired in Turner syndrome and SHOX deficiency, haploinsufficiency of SHOX, which is thought to be a repressor of FGFR3 signaling, will allow for relatively more FGFR3 expression. So you get more inhibition, more impairment of the endochondral bone growth. And when we look at trying to advance the slide. When we look at Noonan syndrome patients, these pathogenic variants result in increased RAS-MAP kinase pathway activation and increased phosphorylation, which then impairs again proliferation and differentiation of the chondrocytes. Next slide. So the potential novel treatment intervention have already been alluded to by Melita in an earlier talk, could be CNP analogs, thank you, vosoritide and navepegritide are two examples. They will lead to an improved counterbalance of the FGFR3 inhibitory pathway, and in this way may improve growth in patients with Turner syndrome, SHOX, or Noonan syndrome. On the other hand, one could block the signaling to FGFR3 with a tyrosine kinase inhibitor, which was already mentioned. Infigratinib will inhibit FGFR3 phosphorylation and therefore also can attenuate FGFR3 downstream signaling. Next slide. Vosoritide is currently the only approved treatment for patients with achondroplasia. Long-term extension trials have confirmed the initial observations of significantly improved growth, and there are now more and more data becoming available that associate this treatment response for growth also with improvements in some of the comorbidities and quality of life. Navepegritide is currently still in the trial phase and recently has completed a phase 3 trial that also showed a superior height velocity compared to placebo in individuals with achondroplasia and may also provide benefits beyond the linear growth response. And infigratinib is also still in the trial phase and also has shown in the phase 2 trial increased height velocity and decreased upper to lower body segment ratio, with also a beneficial mild side effect profile in achondroplasia patients. So next slide, please. So the next 2 slides give you sort of a summary of the main trials that are listed on clinicaltrials.gov that look at Turner syndrome and SHOX deficiency for this slide. And you can see that a number of trials are ongoing or are to be started with different forms of growth hormone, long-acting growth hormone preparations, as well as with CNP analogs such as vosoritide. And on the next slide, I'm not going to go in detail over both, but gives you a list of clinical trials ongoing in Noonan syndrome. And similarly here, long-acting growth hormone preparations such as somapacitan, CNP analogs such as vosoritide are now being investigated for Noonan syndrome. And I know these slides will be available and you can reference to them, and you may have interested patients that would be eligible to enter some of these trials. Next slide. Now, thinking a little bit outside of the box, there are a number of novel formulations under development that have also theoretical potential for improving growth in conditions such as Turner syndrome and Noonan syndrome. And their effect may have been confirmed by in vitro studies or either preclinical or even early studies with humans. For example, Thyroid 300 is a relatively potent and selective FGFR3 inhibitor that was initially designed to avoid toxicity from inhibition of FGFR1, 2, and 4. It was initially developed for bladder cancer and other solid tumors, but is now already or is going to be in a phase 2 study for patients with achondroplasia. FGFR3 signaling can be also attenuated via a number of other mechanisms, for example, with the use of CDK8 inhibitors, which can block STAT1 phosphorylation, and that has been shown in a mouse model, will also lead to decrease in FGFR3 signaling. Anti-FGFR3 monoclonal antibodies may also lead to inhibition of FGFR3 signaling and are being looked at for patients with achondroplasia, but has also been developed for use in cancer patients. I put on there meclizine, which is a over-the-counter antihistamine that has been used for motion sickness. This drug has been evaluated via a drug repositioning strategy with in vitro testing and has been found to be inhibitory towards FGFR3 signaling. Aptamers are small nucleic acid molecules that can bind with a very high degree of affinity to proteins and could also lead to decreased FGFR3 activation. For example, an FGF2 RNA aptamer is currently investigated and considered for this application. And then finally, long-acting IGF-1, because of its ubiquitous role in the growth hormone IGF-1 type 1 IGF receptor as a growth promoter, is being considered by either using a stabilizer-based technology for extended release or via inclusion into encapsulation in biodegradable nanoparticles. So these are some novel formulations with at least theoretical potential also for growth promoting effect in individuals with Turner syndrome, Noonan syndrome, and SHOX deficiency. Next slide. So in conclusion, these three conditions are all characterized by impaired growth and a different variety of associated comorbidities. Recombinant human growth hormone has been the mainstay of treatment for the short stature in these conditions, but growth hormone therapy is certainly not always effective, and adherence issues significantly may affect long-term efficacy. Novel drugs have now been designed to address challenges in and improve the efficacy of short stature treatment via addressing the issues related to short stature that are based mainly in the growth plate and are more target specific with respect to the growth plate. And these newer drugs will introduce a new area of more targeted therapies for children with different forms of short stature, including, and this is my last thing, several clinical trials that are now recruiting patients with Turner syndrome, SHOX deficiency, and Noonan syndrome. And I look forward to the results of these trials. Thank you.
Thank you, Philip, for a great talk. We are a bit behind schedule, but I think maybe there are two questions, I think, for you in the chat. So maybe if you want to just answer briefly to those. The first one is, do you have any experience treating longer mesometic dysplasia with growth hormone?
I don't, no. And I don't know of any particular studies in the literature that have looked at that. There may have been individual cases, but I don't.
Okay, so that's, and the other question was, is there an evidence suggesting that growth hormone at high doses may accelerate bone aging at puberty onset?
So there is a potential that skeletal maturation may accelerate to the higher doses used for a prolonged period of time. But the trials that have looked at increased dosing of daily somatropin have led to significantly improved treatment responses so that the overall height outcome is better using high doses. However, it is best to just initiate treatment with the standard doses, which vary slightly from region to region in the world, where growth hormone therapy has been approved for Turner syndrome patients. And only if patients would not respond well to growth hormone therapy, and or if a diagnosis was made rather late, should one consider using the higher doses. There should be no concern for earlier onset of puberty in patients with Noonan syndrome or SHOX deficiency if it's used. I don't use high doses in patients or quote unquote pubertal doses in patients with growth hormone deficiency.
Okay, thank you. And thank you again for a great talk. And if there are time, we might come back to more questions at the end of this session. So now next speaker and the last speaker for today is Wolfgang Högler, who is Chair of Pediatrics at the Johannes Kepler University and also at the Kepler University Hospital in Linz, Austria. It's a great pleasure to have you here, Wolfgang, and you will talk about treating osteogenesis imperfecta. So please.
Yeah, thank you, Swin. It's already dark here. I hope I can still entertain you as the last speaker. I'll do my best. So the topic is osteogenesis imperfecta, and I start with trying to advancing my slide. Yes, yes, there we are. Several disclosures. I'm the co-chair of the Hyperphosphatase Global Registry study funded by Alexion. I'm PI on several studies to do with rare diseases, be they growth-related or bone-related, advisory boards, and so on. So giving you an overview of what I will talk about, I'll start with just introducing bone fragility and osteogenesis imperfecta to those who are not so familiar with it. I give my state-of-the-art MDT care view, talk, of course, about bisphosphonates to some extent, but then focus on bone pathways and clinical trials in these bone pathways. Lastly, I will just highlight quickly what we can learn from people with OI before I take you home. Right. Why do bones break? We have an easy categorization. Osteogenesis imperfecta, the topic of my talk today, relates to collagen type 1 disorders. Primary osteoporosis are bone fragility conditions not necessarily linked to collagen. There's an osteolysis group, an osteopetrotic group, and the well-known hypomineralization group that causes osteomalacia and rickets in children. And there's all sorts of acquired secondary osteoporosis conditions, and I come to mechanisms shortly. I'm a pathophysiologist to some extent with an endocrinologist, and I'd like to keep things also simple and clear. There is heritable conditions, as always in pediatrics, and acquired ones. Collagen type 1 has a processing pathway that currently we cannot treat, but this is the cause of osteogenesis imperfecta. There's other pathways like the Wnt signaling pathway, the TGF-beta pathway, the Rank-Laurenc OPG pathway that we have learned to understand and develop treatments to alter these pathways. For the acquired conditions, I should mention that all are easy to understand. Immobility triggers lower biomechanical sensing by the osteocytes, so immobility-induced osteoporosis is just a consequence, a natural consequence from physiology. Inflammatory cytokines activate osteoclasts by activating the Rank OPG system, so increased turnover and resorption. Glucocorticoids are toxic to bone cells, and any individual who lacks estrogen, being female or male, will have osteoporosis because estrogen deficiency increases osteoclast action and decreases osteoblast action. So all the acquired forms can well be explained by these conditions, by these mechanisms. But now to OI, with a prevalence of 1 to, well, 15 to 20,000, 2/3 of the cases are mild. As I said, it's a type 1 collagenopathy and mainly dominantly inherited. Most important is to realize that this is a low bone mass condition, with the bone that is there being of extremely high material density. So it's like chalk, but do not mix up bone density results that really show bone mass with material density results where there's very high density. If it affects not just bone and teeth, but it's a multi-system disorder, really, with joint hyperelasticity, deformity, dysmorphism, and so on. There's 5 genital types, one being the mildest form with a normal growth and height, type 2 being lethal, type 3 being the most severe form that is compatible with life, very short stature. Type 4 is moderate for both growth and bone fragility, and type 5 is very special as it comes with hypertrophic callus formation and calcification of intraosseous membranes of the distal limbs. I won't bother you with genetics too much, but these 5 clinical forms all are caused by several genetic forms. There are 23 plus genes nowadays that cause osteogenesis imperfecta. 90% of all forms, however, 90% of all cases are explained by mutations in COL1A1 or COL1A2, the 2 collagen proteins that form the triple helix. And this is the collagen processing pathway, and I'm showing a bit of its complexity. obviously collagen type 1, the COL1A1 and COL1A genes are transcribed and then translated to the two collagen amino acid chains. They enter the ER, and all those colorful dots and numbers, it needs to meet all these enzymes and proteins to be properly folded. All processes that are called post-translational modifications go on in the ER. And then, like other proteins, they need to get out of the cell. So in large transport vesicles, these are ferried through the cell to the Golgi apparatus, where there's still some post-translational modification going on before they leave the cell. And even without outside the cell, there is still modification going on before the final triple helix is being assembled. So you can imagine that all these 23 genes and the 23 proteins encoded by these genes have a lot to do, and therefore any defect in any of these proteins will cause osteogenesis imperfecta. And you also understand, therefore, that it's very difficult to target this collagen processing pathway with a drug. So the mainstay of multidisciplinary care are medical therapy. That's me, endocrinologists, other bone specialists, not necessarily endocrinologists. But you also need orthopedic surgery and specialized orthopedic surgery, I should say, and physio and OT to deliver proper care. If you only have one or two of those elements in your hospital, you shouldn't really take care of OI. As I said, there is no pathway-specific therapy, so we're using mainly at the moment anti-resorptives, bisphosphonates, to reduce bone resorption, and therefore over time in children there will be more formation than resorption, and this increases bone mass. But there's all sorts of supportive therapy that I just mentioned that you need to give or to administer alongside bisphosphonates and all the other issues that come with taking care of disabled individuals. Bisphosphonates have different potency. We only use zoledronic acid nowadays, which is only a short infusion every 6 months for most of childhood and adolescence. The proper or formal studies were done with permethrinate, which, as you see, has far less potency than zoledronic acid, but is still used here and there. In one slide, I summarize all the actions of conventional therapy. With that, I don't mean just bisphosphonate therapy, but overall treatment. On the top left is the famous study published by Francis Glorieux in the New England Journal many years ago, where it shows the increase in bone mass, not bone density, although the DEXA machine says so. It's bone mass that increases. On the top right, you see what happens with sequential bone biopsies, transiliac bone biopsies. The cortical wall thickens, the trabecular, everything green is bone. Trabecular bone increases on the inside as well. So there's just more formation going on than resorption that thickens the cortex and increases trabecular structures. We can reshape vertebral fractures during childhood if we start treatment early enough. Broken vertebral bones can reshape over time. That's not possible in adults, of course, but for extreme joint, the extreme deformity of long bones, of course, we do need specialized orthopedic surgeons to put metal rods in. There's concerns around overtreatment with bisphosphonates. First of all, they may or they do impair bone repair. We need to repair our bones every day, so we need osteoclasts for normal bone repair, and therefore you shouldn't treat for too long, so that micro cracks in the bones can still be repaired. And this is why on the right side I'm saying allow treatment break after the end of growth, because you need to get rid of all the micro cracks. But also because we are treating during childhood, we're treating the growth plates, if we want to or not. And that's when it's overtreatment can lead to undertubulation of long bones, and we are trapping cartilage in mature bone. I'll show you images in a second of those sclerotic lines. But bisphosphonates also delay dentition, and we worry about long-term safety still, although the data are not there to make us worry a lot. So here you see these bisphosphonate lines. They're nothing else but dense lines of hypertrophic chondrocytes that have entered the metaphyses. So we're sending chondrocytes into the metaphyses where they're not supposed to be. Bone biopsies have proven that these dense lines contain chondrocytes and cartilage. Therefore, if you do a PQCT scan, that's here depicted on the right, you have high density, low density, high density, low density lines next to each other. And obviously, we want to avoid that. And at the end of growth, we want to give the body time to remodel also these metaphyses. What can happen with these sclerotic lines is that you have two different material strengths and densities next to each other, which makes us worry about stress rises. Therefore, although this doesn't happen often, it's very rare to see this, but fractures can go through these lines. Right, coming back to pathways. I'm an endocrinologist, so I know about hormones and receptors, and the main hormones active on bone are active vitamin D calcitriol, PTH, and FGF23. We're not interacting there because they're not affected at all in osteogenesis imperfecta. Quite on the contrary, we have a very high mineralization in these bones. We're interested in what the bone cell proteins do and how we can actually interfere to improve bone strength in osteogenesis imperfecta. And this is a summary slide now to depict what's there at the moment. It's pediatric bias, so I'm not talking about adult medicine a lot here, but I'm showing you the different drugs after the era of bisphosphonates that have been trialed and are being trialed, and also non-drug treatments. Let's start with the top. Anti-resorptive therapy with Rankel antibodies. Denosumab is well known as a Rankel antibody, will stop osteoclasts very completely and very quickly. The trial, in the pediatric trial in osteogenesis imperfecta, has been stopped, terminated because of effects on serum calcium. So it causes hypocalcemia after the injection, and then rebound hypercalcemia once the treatment wears off. And we've seen this quite frequently also in other conditions where we use it in high doses, like in giant cell tumors of bones. We have to be very aware of these side effects and take action. But interesting, and this is a really new area, we're all very excited about anabolic treatments nowadays, and that's particularly sclerostin antibodies, so targeting the Wnt signaling pathway. I show you what I mean with that, and randomized controls trials are currently ongoing. There's also attempts to target the TGF-beta pathway, another bone formation pathway. Let's briefly talk about losartan because there's a phase 2 study starting. Synthetic PTH, there's no RCTs in children, although we could talk for a long time about PTH, not today. Growth hormone, there's been a small RCT that is in green because it has been completed a long time ago, actually. And what we hope for to some extent to be able to deliver in the future is sequential therapy where we alternate anabolic and anti-resorptive therapy to boost bone with different mechanisms over time. There's also attempts for mesenchymal stem cell transplantation even before birth. It's a study I will show you, which has been completed, a phase 1 study. And I show you what I've done with a whole body vibration randomized controlled trial in children with OI. Right, so growth hormone therapy. As always, growth hormone therapy improves IGF-1 levels. So this has been shown in this study by John Marini. she also did bone biopsies before and after growth hormone, just to see what happens within bone tissue with iliac crest biopsies. She was differentiated between responders and non-responders, depending on whether they had over or below 50% increase in growth velocity. And there were some changes as expected in the responders, that they actually had increased cortical thickness and bone volume per tissue volume, as well as trabecular number. So growth hormone did something in this trial, not just improve growth, but improve bone strength, at least in those that had a higher response in growth velocity. Another trial in growth hormone with using growth hormone in children with OI was an Italian study that showed in 30 prepubertal children, 12 months of growth hormone therapy in addition to bisphosphonate therapy versus bisphosphonate only. Both groups, and there was type 1, 3, and 4 OI, improved in height SDS. On the right is the change in bone mass or bone density measured. The first year there was no difference, but after the growth hormone was stopped, the group that had received growth hormone was in fact gaining more bone mass afterwards. But it was all small RCTs, and it's not at all standard treatment, and not there's no particular indication to give growth hormone. But it is a fact that it's an anabolic hormone, so I would expect positive effects both on muscle as well as on the skeleton to some extent. Right, and when I say muscle, you need to be aware that the bone muscle system is of course connected. So the stronger you are in muscle terms, the stronger you are in bone terms. Therefore, you can treat individuals with whole body vibration, which I did in a small randomized controlled trial. Children with OI type 1 and 4, so the mild and moderate forms, age 5 to 18 years, and they were gender matched and tenor stage matched. They stood on this platform that you can see down there 3 times 3 minutes twice a day for 5 months or not, and then we measured outcomes were bone mass, of course, body composition, density, also measured by PQCT of the tibia. Given that it's whole body vibration, they stand on it, we expected higher effects in the tibia. We measured muscle and muscle size, muscle force, and mobility in a 6-minute walk test. And what did we find? There was no effect on bone that we could see in these 5 months, but muscle mass increased 600 grams in the controls and 1 kilogram or more in those who went on the vibration platform. So clearly muscle responded to the therapy, and in my point of view, although we didn't achieve a significant effect in this small RCT on bone, there was at least a tendency in the main outcome trabecular BMD there, down there in the table, with a positive change in the whole body vibration group and a negative change in the control group. But nonetheless, certainly we increased their fitness and muscle size. Of course, you can't do this throughout your whole growing period or throughout life to stand on such a platform, but it's certainly an important rehab tool. But now coming to drugs again, and the novel drugs that are out there. And for that, I need to briefly explain what the Wnt signaling pathway is. This is a bone cell here on the right. The Wnt gene codes the Wnt protein, which stimulates this pathway, which eventually leads to bone formation. So Wnt signaling is a strong bone formation pathway. And sclerostin is an inhibitor of this pathway. It binds to the LRP5 receptor, which inhibits the binding of Wnt. In short, sclerostin inhibits bone formation, and therefore it was logical to develop a drug that takes sclerostin away. An antibody against sclerostin would automatically lead to bone formation. And why do we know that? We know that because we are rare disease specialists as pediatricians, so we love genes and proteins and what they do. And we know that that the Wnt signaling pathway, once it's impaired, once it's down, it causes heterozygously osteoporosis or biallelically osteogenesis imperfecta. So there's a gene dosing effect here on the negative side. And then if the Wnt signaling pathway is up, then you get osteopetrosis, sclerosteosis, or Van Buchen's disease. So clearly, like many other genes, there is, like FGFR3 as well, by the way, there's a gene dosing effect. In case of the Wnt signaling pathway, if it's stimulated, you get high bone mass. If it's impaired, you get osteoporosis and osteogenesis imperfecta. So romosozumab is licensed for adults with postmenopausal osteoporosis, and this is one of the main studies. It showed that a massive increase in bone density in adults, more than you would ever achieve with any other drug. In the first year, 12% from baseline in the lumbar spine and 5% in the hip and femoral neck, which was in this study followed by denosumab, so anti-rankle as a sequential therapy to anabolic therapy, which further led to further increases in bone density in these regions. So these are the two studies that are ongoing in children using anti-sclerostins. Stetrosumab is given once monthly as an infusion in the phase 3 RCT at this point in time and has received breakthrough therapy designation and rare pediatric disease designation by the FDA, but also by EMA. And we here in Linz are participating in the study by Amgen using romosozumab in the phase 3 RCT with a once monthly injection. And as I said, this drug is already licensed as an anabolic treatment of osteoporosis in adults. And we're very keen to see the outcome of these two studies in due course. And we would be keen to, for the first time in decades, to have an anabolic drug also for children with osteogenesis imperfecta. The TGF-beta pathway I'm only touching upon. It's also a quite complex pathway that I don't want any questions on. It's difficult, but fact is, losartan is a known drug, angiotensin 2 receptor type 1 antagonist. It reduces TGF-beta 2 levels and also the signaling as such, and in the mouse model increases trabecular bone volume in tibia and vertebrae, increases cortical bone thickness and trabecular bone pattern factor, and it reduced osteoclast and osteoblast numbers. Nick Bishop is leading this trial. It's a phase 2 trial in adults with OI at this point in time, but it's early days. But it's interesting, and drug repurposing is something that is important for us anyway, because there's many more drugs that are out there that may have positive effects on rare disorders. I'd also like to mention the mesenchymal stem cell study that's going on in Sweden, the UK, and the Netherlands, the BOOST B4 trial, which is, there's a postnatal group and a prenatal group who so neonates and even fetuses that are given mesenchymal stem cell transplants. That's 4 doses of intravenous fetal MSCs at 4 months intervals. And the hope is, of course, to improve and to let these transplanted cells replace the mutated cells. I have not seen any results published. It's been going on for a very long time, but I'm also eager to see the results of this study. Last but not least, however, when people think about bone fragility and OI, they think bone density and fractures. But when you ask patients what they worry about most, then bone density doesn't feature. What features is getting older. This is the results of the impact survey. Over 1,000 people with OI answered this. They worry about the ability to care for oneself, living independently, losing independence, losing mobility, and you see the list of frequent features in red and orange. that dominate their worries. And yes, fractures is one of them, but it's not everything. And I think if you take care of individuals with osteogenesis imperfecta, you need to be more than just an endocrinologist or a bone doctor, but see all the multi-system disorders and worry about or share their what should I say, views to some extent and understand what they really worry about. To be a pediatrician in 2025 is quite exciting. Also, not just as a bone specialist and endocrinologist. We, over decades, have given hormone replacement therapies or enzyme replacement therapies because that's what we could do and was great. But the era is changing. So we have not just got antibodies and hormones, we can deal with rare disease in another way. So we know that mutated proteins, they irritate the endoplasmatic reticulum. The ER is expanded, misfolded proteins dwell in there and cells die quickly. So ER stress inhibitors are a potential for the future for many rare diseases that come with ER stress. Also, nowadays, there's techniques to target the mutated mRNA to silence that mutated RNA that comes out of the transcription and translation process with antisense oligonucleotides, with aptamers, non-coding RNAs in summary. These are very individualized therapies, and it's difficult to get pharma interested in this unless there's a hotspot mutation so you can treat several patients or patient groups with one ASO, but in theory, you can target any mutation with an ASO if you have the money. And we live in a time when there's gene therapy available. It's not going to be very soon that treatments will be developed for OI, but fact is more and more are coming. Hundreds are under development for many rare diseases, and I hope I will see a treatment coming up for OI at some stage. So there's a lot happening. Lots of pathways are also better described nowadays to find targets in there for drugs. So it's an exciting time to be a bone specialist. So take-home messages are that clinical trials are still sparse in children with OI. Overall, at least, that the collagen pathway can only be targeted with the most modern therapies, ASOs, siRNAs, gene therapies in the future, not at this point in time. And that we have learned to target other pathways all around bone, but not around collagen, Wnt signaling, TGF-beta, ER stress, and the muscle system. The biomechanical sensing system is a wonderful treatment target if patients can at least stand on a platform. We are, like Eureka in Europe, now collecting data in the OI module. There's an Achon module, there's an OI module, and I invite everybody who's on the online today to contribute to the collection of information on rare diseases. I've shown you what patients with OI want, and I thank you for your attention.
Thank you, Wolfgang, for a very informative overview of the treatment options of OI. That was really great. Are there any questions for Wolfgang? I can't see any in the chat, but are there any questions from the audience? It's late, but I think we have maybe one or two questions left from the previous discussions in case when you are still thinking of questions to Wolfgang. I think there's a comment that we need a consensus on diagnosis of achondroplasia or the diagnostic criteria. Yes, I think that will be part of the consensus guideline work. And I think there's another question to you, Andrew. What would be the best way to study neurocognitive problems in hypochondroplasia because it's much of their life they are more impact than problems related to height or other comorbidities. So do you want to give a short comment on that?
Sure. I think that there are more advanced neurocognitive testing, right? Developmental testing, attentional tests that they do, to test kind of attentional capabilities, like when you're evaluating somebody for ADHD and full neurocognitive profiles. I'm not really an expert in those tests, but I think that those haven't been done uniformly across an entire cohort of children with hypochondroplasia, as opposed to just, individual patients for whom there's a clinical concern. So I think engaging with neuropsychologists and trying to figure out, doing a study where we would kind of comprehensively evaluate an entire cohort of children and see what the range is of the spectrum and whether there are any specific types of processing defects or things would be helpful. Just haven't taken that up yet.
Yes, thank you. I think Wolfgang, you raised your hand.
Yes, this is for Melita and Andrew, maybe. Infigratinib is a FGFR3 1-3 selective inhibitor. And I'm sure you're well aware that FGFR1 and FGFR2 also have monogenic conditions associated with them. So if you inhibit FGFR1 and 2, there is, of course, a concern of toxicity. I'm sure you don't cause Pfeiffer's disease or Appert's disease, but nonetheless, these are physiological receptors that have a meaning in life. I've seen the New England Journal paper on infigratinib, but do you envisage that there may be issues with these other two receptors being hit by the same drug?
Melita?
So you want to take that? Sure.
Yeah, so yes, infigratinib is not selective to FGFR3, it's selective to FGFR1, 2, 3, and 4, and so therefore there are off-target effects. I wouldn't necessarily call them toxicities, but yeah, definitely off-target effects, which we monitor for in the trial setting and which we try to mitigate against, and so far all good. But yeah, those are considerations. For sure. And so Tyra is therefore remarkable because it targets the FGFR3 tyrosine kinase domain specifically. And so we are expecting fewer off-target effects in that respect.
Just to add to that, with any drug, there can be off-target effects or toxicities, and a lot of times it just is a dose-response relationship, and at what dose do those toxicities become clinically meaningful or problematic? So I think that what's important to know is, at least with infigratinib, there's a whole bunch of data available from its previous use in the adult oncology world, and that the doses currently being used for achondroplasia and hypochondroplasia are much lower, 7-fold or so lower than what was used in the adult data. So while these, I agree, are kind of more our theoretical concerns, the proof, as they say, the proof will be in the pudding. So we need to just wait and see if any of these concerns actually show up in the clinical trial at the doses being used.
I think we have time for maybe one more question. Are there any? Otherwise, I think there's still one question left in the chat. I think that was from Rhoda. Are you aware of any data on improvement of or worsening of body proportion using growth hormone in SHOX deficiency in those with significant mesomelia? I think that was to you, Philip.
Yeah, so I'm not aware of any worsening of disproportionality in the trials with SHOX deficiency patients being reported. There have been few small studies. There's significant variability in the patient's phenotype. There was one meta-analysis that didn't say anything about improvement in body disproportionality. What I can say from extrapolation with Turner syndrome individuals is that growth hormone therapy in these patients does not improve the height disproportion when you look at sitting height over height ratios. And probably this is related to the fact that we don't really address the underlying pathophysiology with just giving pharmacological doses of growth hormone.
Brilliant. Thank you so much. Apology. Thank you, Svein, for asking my question. I have the Arsenal match going on in the background, so I didn't want to turn my microphone on. But yes, it's just because we have a patient with langamesomelic dysplasia, and the mesomelia in that patient is extremely severe. And so my worry was, if there is no improvement in disproportion, and in fact, if the disproportion gets worse, treating a patient with langamesomelic may make that significantly worse, because I think the main issue with this particular child is the disproportion and how that's impairing that child's function. So it was just, you know, whether you felt, because of the data in the past of disproportion possibly being more of a problem using growth hormone in achondroplasia in the past, you know, whether that's something that you might see in shocks if disproportion is an issue. So no, thank you. It's really helpful.
Okay. I think we need to wrap up. It's been a very, very interesting workshop. Thank you so much to all the speakers for very informative talks. And thank you to all the attendants for questions and being active with the chat. I also would like to thank the CSIS team for providing all the support, both in preparing this workshop and for supporting us during this workshop. And you will also assist us in the after work. So, and I would also like to thank our sponsors again, QED, Biomarine, and Tyra. Without you, this would not have been possible. And this workshop has been recorded, and I think it will be published on the IAF website. And also there will be an editorial piece on achondroplasia and related conditions after this, so you can look on that for our website. And there is short, I think it's a very brief evaluation. When you close this meeting, please respond to that. And again, I would like to thank all the presenters today and wish you all a pleasant evening and good night to all of you. And thank you for attending.